Thank you. So I'm Dr. Brand. I'm the Clinical Director for the White Bay Mental Health Service in Australia and Queensland. And I'm very privileged to be in this beautiful country today. Okay. So it's a privilege today for me to introduce one of my patients that I've met back in New Zealand. Let's call him Mickey for the time being. So Mickey was a 24-year-old Indigenous Maori male. He had a family history of psychotic disorders. His father was diagnosed with paranoid schizophrenia. He had quite a disruptive upbringing, with a lot of exposure to drugs, gangs and violence in central New Zealand. At the age of 3, his father passed away during a drug deal gone wrong, and he was shot dead. He was raised by his stepfather, and generally things went quite well. However, there was an incident when he was 14 years old where there was an altercation with the stepfather, and the stepfather tried to strangle him. But apart from that, he had a really good relationship with the stepfather. Mickey started using cannabis and marijuana in his early teens, and at the age of 17 he was diagnosed with a psychotic illness. At that stage they diagnosed him with psychosis related to illicit substance use. He was well known to the youth justice system, and he had committed several petty crimes. When he was 18 years old, he committed armed robbery. In New Zealand, as well as in Australia, there's an insanity defence for people that's been found unsound of mind. Whether this young man at the age of 18 should have been found unsound, I'm not quite sure. However, he ended up as a forensic inpatient in an inpatient unit in New Zealand. So a forensic inpatient unit is a mental health hospital that deals with people that's been found unfit to stand trial or unsound of mind. He stayed with us for 5 years, and that's where I first had the privilege of meeting him and then treating him for 3 years. First of all, we had some diagnostic clarification. He continued to experience hallucinations and delusions, despite the fact that he was not using any illicit substances anymore. The confinement of the mental health hospital made it impossible for him to get any drugs. We managed him on olanzapine, that's a monotherapy antipsychotic medication that's really good for paranoid schizophrenia, and that was his diagnosis. During his 5 years with us, he went through drug and alcohol counselling. He also had some cognitive behaviour therapy to treat some anxiety. He had social skills training. There was issues with his literacy because he grew up in quite disruptive upbringing. So he went through to about a year 8 level with the help of the people and the occupational therapist in the hospital. At the end of his last 5 years, he started working as a packer in one of the supermarkets, and that was also supported through the hospital system. And one of his most favourite pastimes was cycling. So he got himself a mountain bike and he was cycling all over town while still being a forensic inpatient. So the time was right and he was doing really well. So we decided that we'll exit him back into the community. However, because of his literacy difficulties and the fact that he couldn't manage his finances, the occupational therapist has decided that he needs level 3 supported accommodation. His mental illness was treated and he was no longer using any illicit substances. So we found a really nice place with a number of people. I think at that stage there was living 15 people that had all forensic patients that were living back in the community. And as things happened, on a Friday afternoon at 3 p.m, I got a phone call from the supported accommodation requesting that they take this man back immediately. They stated that they found him with a pillowcase around his neck, tied up, and he was masturbating. At 3 o'clock in the afternoon, admitting someone back in a forensic mental health hospital with no mental health issues was quite difficult. And it raised a few questions. What are we dealing with? What is the risk? And how do we manage it? So what we were dealing with is autoerotic asphyxiation. and that's the practice of limiting the flow of oxygen to the brain during masturbation in an attempt to heighten sexual pleasure. Depending on where you practice in the world, this is called asphyxiophilia, Auto-Erotic asphyxiation, or hypoxophilia. But going back to Mickey, this practice where he'll put the pillowcase around his neck and wind it up while he's masturbating started during the episode when he was 14 years old, when his father attempted to strangulate him. During the strangulation, he got aroused and had an amazing orgasm, and since then he could never gain an orgasm again without having some sort of autoerotic asphyxiation. He engaged in this practice 2 to 3 times per week for the past 10 years. He always used a pillowcase over his head, was always alone, and this young man had no history of sexual violence or sexual offending. We knew about his autoerotic asphyxiation practice all the time he's been in hospital, where it initially caused some angst, and he was offered CBT and all different kinds of treatment. He stated that he had no desire to change it and he was happy with the practice. It took a lot of education to our own staff and able to manage this in a hospital setting, but for the supported accommodation it was too much. So is this a disorder? Is this a mental illness? So if you look at the DSM-5, we can only diagnose a paraphilic disorder if there's a persistent and intense atypical sexual arousal pattern that are accompanied by clinically significant distress or impairment. Or in other words, we have to prove that there's risk associated with it. And clearly, this guy trying to choke himself is at risk. Or is he really? So having a paraphilia is a necessary but not sufficient condition to have a paraphilic disorder. So I decided to look into what is the risk of autoerotic asphyxiation. Obviously it sounds very risky. Anyway, this young man enjoyed cycling. I couldn't find any Australasian or New Zealand data, but in 2013 in the United States alone, 900 cyclists were killed and there were over 500,000 emergency department visits just related to cycling accidents. So what is the risk of autoerotic asphyxiation then, if we compare it to cycling? First of all, we need to know what's the prevalence of cycling and the prevalence of autoerotic asphyxiation. And unfortunately, if any one of you ever try to do research on any paraphilia, it's extremely difficult because no one will put their hand up to agree that they engaged in these practices. So I had to try and find out what's the prevalence in some other way. So we know in the United States there's around about 146 possible deaths related to autoerotic asphyxiation. Still, it doesn't really give us a prevalence. So I decided to put sexual choking in a Google search, and there was 20,900,000 results. So something tells me somebody is doing this, or at least looking it up. There's also websites related to sexual choking. And X-Videos, that's a very popular pornography site, had 6,720 uploaded videos per year. So someone is making it, someone is watching it. And there's even websites like chokechicks.com that's just dedicated to autoerotic asphyxiation. Also, 50 Shades of Grey, that you must all be very, very familiar with, sold over 125 million copies. Although 50 Shades of Grey did not specifically focus on autoerotic asphyxiation, it focused on paraphilias and perhaps even paraphilic disorders. So let's get back to the risk again. Mickey was engaged in autoerotic asphyxiation twice a week, 2 to 3 times a week, for 52 weeks a year for 10 years. So for at least 1,040 times, there was no adverse outcomes. He did visit ED twice because he fell off his bicycle. And that tells me I can't diagnose him with a mental illness. This is not a disorder. It's a behavior and it's a paraphilia. And something that's quite egotonic to him, he enjoyed it. So who are we to try and change that behavior? Obviously, it took a whole lot in management, psychoeducation and safe sex practice and advice to convince the supported accommodation to acknowledge the behaviour and respect that, and not to feel that they are unnecessarily placing himself at risk. We also have to acknowledge that he never engaged in any deviant sexual behaviour and there was no partner involved. Actually, if he had a partner, it would have been even less risky. However, this has led me to think about what is the sexual experiences and sexual knowledge and sexual education that our patients, the forensic order patients, experience. And we could find no quantitative and no qualitative data on what the actual experiences of people on forensic orders. And hence I submitted a PhD protocol that's now been approved by the ethical committee, and we started collecting some research. It's a cross-sectional study that will use survey questions during face-to-face interviews with the aim of quantifying the sexual development, experiences, knowledge and health of people with major mental illness. So our focus group will be specific forensic order patients. Interestingly enough, of the 50 people that we plan to survey in Queensland, only 3% has sexual deviant behaviour or had an index offence related to a sexual assault or indecent assault. However, looking at the forensic order population, you look at risk, and because people are so afraid of sexual deviant and risky and unlawful behaviour, no one takes care to ask people about what is their sexual experiences or what do they want to do. So my hope is by understanding this potentially vulnerable population's sexuality and sexual health needs, our research team will aim to identify areas where evidence-based interventions can enable these people to have a fulfilling sexual experience. Any questions?
Thank you for erudite lecture. My question is, how does asphyxia causes sexual erection? How does asphyxia leads to erection?
What they do is once they the reduction of oxygen to the brain enhance the orgasm. They don't know how it works. I think it's again one of those really difficult things to research, because no one wants to come in and say that yes, they do it, and they are happy to engage in research in this particular field. On the other hand, we know that this happened. It might be. Yep, it's a depression of the respiratory center and an enhancement of an orgasm.
Any other question? Thank you very much for a nice lecture, ma'am. Thank you.